So the next presentation is from Bev Teicher, who will be talking about strengths and limitations of traditional preclinical models.
So I'm here to address the mouse today. And I want to make sure that everyone knows that the opinions I express are mine and are not NCI policy. So starting in the 1960s, we had transplantable syngeneic tumor models. Most of these were developed by chemically induced tumors. These models are still used today quite extensively. They have low cost. They use conventional mice. They're very reproducible, very nicely in today's environment where immunotherapy is very popular. These hosts are immunocompetent. There's some variety, not as much variety as one might like. Most of these tumors are not immunogenic. They have a long history, and therefore they have a strong baseline of data. We know how these tumors behave with hundreds of anti-cancer agents, and this gives the experimentalist a good feeling for whether this is a drug-resistant or drug-sensitive tumor and so on. The hosts are readily available, and because these are relatively low cost, you can do statistically significant numbers of animals and repeat the experiments. So those are the advantages. The disadvantages are that these are rodent tumor cells. The tumor cell lines are quite old. They've been around for 40 years or more. They're often implanted subcutaneously, and the subcutaneous space is just a lousy place to implant a tumor in terms of the biology. In terms of the experiment, it's an ideal location because the tumors can be readily measured from the outside. The proteins and enzymes targets are rodent. So when we test new agents that could potentially become drugs, we're testing them against the mouse enzyme. We're not testing them against the human enzyme, which may not be the same. The hosts are rodent, the immune system is rodent, and the rodent immune system is quite different than the human in many ways. And they grow very fast. So 2 weeks, 3 weeks, a month, and your controls are already too large. So in the 1970s and 80s, human tumor xenografts were developed, and these original human tumor xenografts were developed usually either from cell lines or from implanting human tumor cells in mice. And these are nice because the tumor cells are human. They're very reproducible. There's a wide variety of them, and now there's a long history with these tumor lines. There's a strong baseline of data. These are well-known lines by those of us who work as experimentalists in this area. The hosts are readily available. The tumors grow easily, and the growth can be followed easily because they are implanted subcutaneously for the most part, and statistically valid numbers can be achieved. The disadvantages are that they are more costly than the syngeneic models. These are usually either nude mice or skid mice. The stroma is rodent. That includes the vasculature and the microenvironment and the macroenvironment that these tumors are growing in. The hosts are immunodeficient, and therefore we can't test immune therapies on them. The subcutaneous site is just a very unnatural site for the growth of the tumors, and I think really compromises the understanding of the response. Most of the tumor cell lines are old, and those of us who are engaged in PDX modeling these days feel that these old lines may not be good representatives of the human disease any longer. And genetic diversity is limited, and that has really become clear. I'd like to discuss just briefly what I would call disseminated disease models. So these, in this case, most frequently, the tumor cells are injected intravenously or by some other injection route. These are more like clinical disease in some ways, however, because the tumor cells can home to tissues. However, most of the time, the tumor cells lodge in tissues. So these are not really models of metastatic disease, but we can call them disseminated disease. The variety is most of the syngeneic models and the xenograft models that were in the first two slides. The hosts are readily available. For the syngeneic models, the hosts are immunocompetent. For the xenograft, they are immunodeficient. The disadvantages are that you need somebody with good hands who's very skilled, who can do IV injections into tail veins or left ventricle injections into the heart. And because these are more complicated in that sense, usually the number of animals used is lower. Again, the stroma is rodent, the immune system is rodent. The tumors are more difficult to follow because now they're deep in the animal's body. And the tumor lines are old. Making statistics are more difficult because we usually use smaller numbers of animals, and sometimes survival is used as an endpoint. You can do disseminated disease experiments from subcutaneously implanted tumors. Most of the time, this is not done because it is more work. But if you grow a tumor, in this case, let's say a syngeneic tumor subcutaneously in a mouse, you can excise a variety of tissues at some point, prepare single-cell suspension, and then grow these cells for tumor colony formation in vitro. And in this experiment, the EMT6 mouse mammary carcinoma was used, allowed to grow subcutaneously for 9 days, and then a variety of tissues were excised. And if you look here just at the control, you can see the number of tumor colonies that developed from various tissues. So there was tumor in the subcutaneous tumor, in the liver, the lungs, the circulating blood, the bone marrow, the brain, and the spleen. So that there was disseminated disease that disseminated naturally from the subcutaneous tumor. But doing this experiment for drug discovery is a lot more work than doing a subcutaneous experiment. Now here's a disseminated disease model. That's the 4T1, again, a syngeneic mouse model. And in this case, the tumor cells were injected into the left ventricle of the heart. And you can see here, they went to the bone. There's a mammary carcinoma. It went to bone, and you could see the damage to the trabecular bone and the tumor growth in the bone, which allows treatments to be administered that might be useful in treatment of bone metastasis. And this is my one rat slide. The rat is also a good rodent model for cancer, and this is a 13672 Ratmammary carcinoma. In this case, the tumor cells were actually injected into the tip of the femur with a 27-gauge needle. Just a few tumor cells were implanted. And again, you can see the growth of the tumor in the bone over time. The nice thing about rodent models is there are a lot of reagents that can be used. And you can see the immunohistochemistry that was done with this model. There's also a lot of reagents of this type that can be used for mice, fewer for the dog. Now I'd like to talk about labeled tumors, and this is perhaps the tumor model that I have the most trouble with. These are either labeled with a green fluorescence protein or red fluorescence protein or luciferase. These are the types of models I'm discussing here. And the tumor cells, the advantages are that the tumor can be followed by fluorescence or luminescence. Therefore, metastasis can be visualized in these animals before there's any nodules, and you don't have to excise anything. The tumor measurements are often a little quirky, photons or pixels, something of that type, but you can see growth or shrinking. The variety is limited for these tumors, and the hosts are readily available. The disadvantage is that these are genetically altered sublines, and these sublines have been genetically altered in a way that their transcription and translational machinery has been co-opted to make a jellyfish protein or a Drosophila protein. So to say that these are good models of human disease is a little tough for me. Many of these lines are clonal. I feel personally that these it's difficult for me to understand these as a good representation of the disease. The animals' numbers used in these experiments are frequently lower because very few animals can be imaged at the same time. So if you have to image every single animal, it can take quite a lot of time. The rodent is stroma, the hosts are immunodeficient, the equipment for doing the visualization is costly, and statistics become difficult. Shown here is a recent paper where a human pancreatic cancer xenograft was implanted by ultrasound-guided injection into the pancreas of the mouse. And you can see the ultrasound images here. As it turned out, this was also a green fluorescence protein tag subline, so that other images in this paper also showed the green fluorescence imaging of the tumor. So recently, because we've grown dissatisfied with the models that we've had in hand, there's been a great effort to do patient-derived xenograft models. The patient-derived xenograft models are taking a bit of a patient's tumor and implanting it directly into an immunodeficient mouse. And there are two ways to think about these models. The first I'm showing here is the personal cancer avatars. So in this case, we have to start with a relatively large specimen of the patient's tumor, usually from a surgery, and implant that directly into mice and, cross your fingers and hope it grows. And you have to start with a relatively large number because you want to be able to use the tumor cells. That's called the P0 passage. So if those tumors grow, you can then pass into P1 into a larger number of mice. And the idea here is to use the tumors as early as possible. There's no expectation here of making a permanent tumor line. The expectation is to use the information you get from this one experiment to the patient's advantage. And so the tumor cells are recently as possible from the patient, used in the P1 setting, the P1 passage. Therefore, we hope they are genetically as similar to the patient's tumor as possible. These tumors are almost always implanted subcutaneously. The hosts are readily available, and these are usually NSG mice. The disadvantages are that you have to start with a relatively large tumor specimen, and so this is usually from the first surgery. These grow very slowly. So it may be 6 months, 9 months until you have enough tumor material to pass from P0 to P1. Again, in the next passage, it could be 6, 9 months before you have enough tumor material to do a study with. The hosts are immunodeficient. Again, the stroma is mouse. There's low numbers of animals. It becomes very costly. The idea here is that to do enough, test enough drugs in this setting, that it may benefit the patient when they get to second line, third line, or fourth line therapy, obviously not the first line therapy. And there is not yet enough data to say whether these kinds of models are valid predictors of whether the patient's tumor will respond. Another way to think about patient-derived xenografts is to actually be making new transplantable tumor models. And the motivation for this is that we have discovered that the existing xenograft models really fall short of representing the spectrum of human disease, both in terms of the metastases that are present in diversity within a specific cancer and the diversities of cancers. Now, why would there be motivation for doing this at this point? We now have a new host, a host that is more immunodeficient than the host that we had in the 1980s. And we have new technology for helping these tumors grow in early passage. So these are then passed multiple times in mice, and the hope is that they will form new transplantable xenograft models that can be used by the community. Many of these are very well genetically characterized because they're characterized genetically with the technologies we have today. Most often they are implanted subcutaneously and the hosts are readily available. The disadvantages are that the hosts are very immunodepressed, deficient. The stroma is rodent. There's no baseline data with these. These are unknowns. They're become very costly. The animal numbers are low. They're often very slow growing. So statistics are difficult, and they have not been validated as yet. GEM models are genetically engineered mouse models of cancer. These have come a long way in recent years. However, genetically, they are clean, you might say. These tumor models may have an oncogene inserted into them. They may have a tumor suppressor gene deleted. So they often, these days, have at least 2 genetic alterations in them. And the thought is that if they get past, there will be more mutations as time goes on because they're more genetically unstable. However, they're clean. They don't represent a patient who may have lung cancer from a long history of smoking, for example. The tumor arises in the desired tissue. You can now genetically engineer these so that they arise in a specific tissue. The lesion is well defined, and the mutations, the deletions, the genetic alterations are well defined. And they can be used to follow the time course of cancer development. And in some cases, there is an immunocompetent host. The disadvantages are there's the limited number of alterations in these tumors may not be reflective of human disease. The tumors are often rodent. They're slow to develop, so that the animals may not develop a tumor nodule till they're 24 weeks old or so. They require breeding, so they need to be bred, and breeding is costly. You may find, because the tumors are visceral in many cases, that there's a variable stage of tumors and tumor growth. There's more heterogeneity in tumor size in these animals. The tumors are difficult to follow, statistics are difficult, and in many cases, survival is used as an endpoint. But the bottom line with the mouse is a hardy host. And this is kind of the crux of the problem. The mouse remains the most useful and most malign host for cancer models. And it is generally hardy compared to human patients or canine patients in terms of response to drugs. The most commonly used measure for mouse normal tissue toxicity is body weight change. You put them I put them in a scale, you measure them. And if a treatment produces 20% body weight change, body weight loss, if it's associated with a moribund condition, then this is deemed toxic dose. In all cases, in early drug discovery, every compound that's tested in a mouse is taken to the MTD, because this is how we do it. We have no clue whether this compound's ever going to get into a human patient. We have no clue what kind of drug level we'll ever get in a human patient. Therefore, we do the phase 1 study in the mouse. We take it to the MTD. And the studies and experiments that are done early on are done at the MTD or one step below the MTD. Now, one example of a sensitive normal tissue that is often dose limiting, at least with classical chemotherapy in the human, is the bone marrow. And I'd like to just show you an example of the difference between the human and the mouse bone marrow in response to some classical anti-cancer agents that are topoisomerase I inhibitors. So this is dose or concentration on a log scale. And in this case, the mouse bone marrow is more than 10-fold less sensitive than the human. The human is more than 10-fold more sensitive than the mouse. And in this case, the differential is over 100-fold. So the mouse can withstand doses of these anti-cancer agents that human patients just cannot. But we don't know that until after there's clinical information. But even then, there's a great reluctance to back off the mouse dose to what a human can tolerate, because then it doesn't work. in the mouse. So another aspect of the mouse that makes it a maligned host is the tumor microenvironment. So the subcutaneous space is just a poor place, has a poor microenvironment for the growth of almost anything. However, if we wanted to do an orthotopic implant, that is, implant a colon cancer in the colon, or a breast cancer in the breast, or so, that often involves some surgery. You know, if you want to put tumor in the cecum of a mouse to do a model for colon cancer, you do a little surgery. If you want to put it a kidney cancer in the kidney, you do a little surgery. We then are faced with wound healing. And wound healing produces a wonderful cytokine and growth factor storm, which boosts tumor growth. So it becomes kind of a catch-22. In many cases also, the communication between mouse and human signaling pathways is imperfect. In some cases, it's just not there at all. The human does not respond to mouse interferons. The mouse does not respond to human interferons. An example of a drug discovery area in recent years where this has been a great problem has been with c-Met and human and hepatocyte growth factor. The mouse and the human signaling pathways there just don't mesh at all. So there's been an effort to develop a mouse that expresses human hepatocyte growth factor to help with that. The mouse immune system is also quite different than the human. And there has been and continues to be a great effort to produce mice with human or humanized immune systems so that we can test immunotherapies in a mouse with a human tumor and a more or less human immune system to see if these will work. And the mouse often has different pharmacokinetics and metabolic handling of drugs than a human patient. It's not only a matter of dose, tolerable dose, but sometimes it's also a matter of metabolism being different in the mouse and the human. Here's an example of a classic anti-cancer agent, cyclophosphamide, just to show what the effect of the microenvironment can be on the tumor cells. So in this case, the subcutaneous tumor was grown and allowed to metastasize, produce metastatic disease, and different tissues were collected, and the response of tumors from these different tissues was measured. And as in the human patient, tumor in the brain and tumor in the liver was most resistant or least responsive to the drug. The subcutaneous tumor was quite responsive, probably more responsive than a natural tumor would be. And tumor in the circulating blood and the spleen was absolutely wiped out by this therapy. But you can see the spectrum of the same tumor cells just naturally lodging in different tissues, that if we're depending on subcutaneous tumors implanted in mice to be our guidepost, this is part of the reason why we're getting over prediction. So in conclusion, transplantable tumors in mice are often poor mimics of human cancer, whether we're talking about syngeneic tumors or xenografts. GEM models have advantages and disadvantages. Are they better models of the human disease? I think they are getting to be better models over time. They're getting better and better. But we have to remember that the mouse is a hardy host and has led to inaccurate predictions of compounds in human cancers, in part because it can tolerate drug doses or compound doses that are much higher than patients can tolerate. And the mouse tumor microenvironment does not accurately reflect the microenvironment in human cancers. Thank you.
Okay, any pressing questions for Dr. Teicher? So Bev, I'll ask one. With the microenvironmental effects in the mouse, the same could be said of the human, that the same tumor in bone or bone marrow or liver or
Absolutely.
lung will have different responses. Is the mouse in any way predictive of those different response sites in the human?
Well, if you allow the tumor in the mouse to metastasize naturally to those sites, it could give you a more accurate prediction than the subcutaneous tumor. But most of the time, that's too much work. It's difficult to do that experiment. And so the tumor cells are injected IV, which bypasses a lot of the steps in metastasis and doesn't really accurately produce metastatic disease because the tumor cells kind of lodge in different tissues. They don't arrive there the way they would in a natural metastatic process. So although that experiment could be done, it's not done very often.
You mentioned about the mouse being a hardy host, being less susceptible to certain toxicities, maybe not being a great model for evaluating clinical toxicities. From, again, historical data, do we know about the comparability of toxicity susceptibility in dogs?
Myrtle, do you want to take that one?
And yeah, to the general audience.
Come up. Myrtle is our NCI toxicology expert.
Actually much more an expert than I am. But the non-clinical studies to support safety for phase 1 clinical trials often involve the use of a rodent and a non-rodent species. Whether one chooses to use a canine species or another type of non-rodent species would be agent dependent, and whether or not, the species of choice is appropriate for the agent, meaning if it's a targeted therapy, perhaps that non-clinical model may or may not have the appropriate targets, et cetera. But in most cases, a non-clinical safety package would include a dog or a canine model as part of the safety package. Whether or not a mouse is used to assess safety for the non-clinical safety package is another question, because actually the non-clinical data to support efficacy would not necessarily be used to support non-clinical safety. John, if that's okay.
Thank you, Myrtle.
Because I think in the talk, a little bit was combined. And so usually the mouse model is used for efficacy, and the biggest problem is if you can understand potency against the target in the mouse versus potency and PK relationship to humans. So there's a lot of work done around potency and PK comparisons between mouse and predicted in humans.
That's true.
Safety is not evaluated in mice
Right.
for the most part. You might as well use a plant. So we know that they're very poor predictors of safety, which is why we go to a rat, and then when you combine them with a large species, if you can, your ability to predict goes up. But otherwise, in general, a single species doesn't usually predict very well safety, to answer your question.
Right. And we never know what species is going to be closest to human, but we want the most sensitive safety species to dictate the starting dose. Right.
So one question, and I'm remiss for not asking speakers to identify themselves before you ask the question.
Dan Gustafson, Colorado State. When you talk about mice for use and toxicity, though, if you use right doses and look in the right tissues, you can actually get pretty good answers. I mean, if you're using camptothecins, you need to look in the GI, right? I mean, you can do toxicity, but the animals need to be used a little smarter sometimes.
Well, safety is hardly ever assessed in a mouse. Rats and dogs primarily. But if you know what you're looking for, you can find it in the mouse.
Yeah, if you have the right biological endpoints, you can look at
the mouse does not get the the mouse doesn't do diarrhea, so
No, but if you look at proliferation in the crypts and those things, you can get
Yes.
good answers. I mean,
Yes,
if you look in
yes.
the right place.
Yes. If you, yeah.
Okay, thank you very much, Bev.
Thank you.